All right, well, good afternoon, everybody. Thank you for joining us today to listen to our guest speaker, Paula Hensel, present on perinatal substance abuse and the effects to moms and babies. Paula sits on our overdose fatality review team for Portage County, and so this is kind of a collaboration between the child death review and our overdose fatality review teams regarding this presentation. It was specifically asked for by interest and relevance to a lot of the work that we do. So I want to thank Paula for taking the time today to be here with us. But before I tell you more about Paula, I wanted to touch base on a couple of record keeping items. Again, this presentation is being recorded so that it can be shared and used in the future or to others that weren't able to attend today. And to better understand who our audience is today, if you could just please type your name and organization in the chat. And if you would like a link of the recording sent afterwards, please also include your email. So Paula comes to us from the Family Health Center, Alcohol and Drug Recovery Center in central northern Wisconsin. And she has a doctorate of nursing practice. And she serves as a nurse practitioner in her current role. In her 23 years with the Marshfield Clinic Health System, she has provided patient services in the departments of general internal medicine, urgent care, and now alcohol and drug recovery services. Outside of the Marshfield Clinic Health System, she has been a clinical assistant professor for the graduate nursing program of UW-Eau Claire. And then prior to becoming a nurse practitioner, she was a staff nurse in the settings of the emergency department and public health. She also has over 25 years of pre-hospital EMS fire and rescue experience. So again, thank you, Paula, for being with us today to lend your knowledge and experience on this subject. And I will turn it over to you.
Okay, thank you for that wonderful introduction. It's always quite humbling when you hear people read off what you've done in your life, but I know most of you are from the public health and social services setting, and it's always been a pleasure to come back to my roots where I started, and I still stay very close with the folks that I worked with at the Wood County Health Department and Sue over there. So it's good to come home. Today we're going to talk about mom and baby and the journey to birth with recovery along the way. The photo credit is actually from Dr. Belingasai. He was the medical director for our program for a long time when it was part of St. Joe's inpatient and outpatient programs there. He recently retired, but he stopped and took this one day. I believe he was on his way into work, and it was just a wonderful picture that gives us hope and shows that road to recovery. So our objectives today, I want to talk a little bit about the prevalence of substance use and the substance use disorder in women of childbearing age and pregnant women. Review how the substance use disorder affects pregnant women, moms, and the babies, and recognize what we through Family Health Center Alcohol and Drug can offer to this new little family. So just a little bit about the history of our program. We are a federally qualified health center. Our director is Sheila Wykes. She is tenured, as she calls it. She has about 40 years of experience in the Marshfield area providing addiction medicine services. Our assistant manager is Vicki Parker. I believe they started their journey together at about the same time. When she was at the hospital, she was the systems integration coordinator, meaning she helped people transition from intake all the way through their inpatient stay to outpatient services. Our clinical coordinator is Tammy Newman. She does a lot of our staff. At the time in the hospital, she was a staff nurse and did a lot of the case management, including insurance and dealing with all of those issues and making sure that patients were in the right level of care, and is now with us in our hospital-based program, providing consults there. Dr. Justin Shane is our medical director and a psychiatrist. He was part of the program in the hospital and is now working as our medical director after Dr. B retired. So when we think about this, we have over a century of expertise and strength in recovery care services. The original band, as they like to call themselves, were very instrumental in developing withdrawal management practices that resulted in decreased complications, decreased length of stay, and increased retention in addiction treatment services. And along with all of that, improvement in the quality of life for our patients. So our mission is to provide patient-centered trauma-responsive services for people affected by substance use. And this just isn't the patient themselves. We also provide family services for those affected by the individual's use. Our vision is easily accessible quality care for people affected by substance use. Right now, we have 3 clinic locations in central and northern Wisconsin. First was established in our Minocqua Center in 2016. Marshfield came 2 years behind, and very quickly after that, Ladysmith opened in 2019. And if you think about how this lays out on the map, we're a triangle, and all sites are about 2 hours apart. We do utilize telemedicine quite a bit, as I do see patients at all 3 centers. We do have a hospital connection. As I spoke about, Tammy was very instrumental in the patient case management when they had a hospital-based program at St. Joe's, and now she is working with our inpatient referral service. Patients who are admitted through MMC Marshfield, if they trigger on the screening service, they get a referral to Tammy and Karen, who are the primary nurses that do the consults. This is a free service. They provide information about substance use disorder resources for the patient, families, and of course the staff. And they don't necessarily need to come to us for services. They will connect them with whichever service that their insurance pays for or is closer to their home. They do use Espert for the patients, and sometimes they visit them multiple times. And Tammy can tell a delightful story of a patient who had been referred, and the staff nurse on the floor was talking to her about this is going to happen. She's like, "Oh, don't worry, Tammy's going to come see me. She comes and talks to me all the time." So it's a connection, and sometimes it does take that 7 times of connecting before people engage. So let's talk about overdoses for women. This is a graph of what has happened in the United States over the last several years, the last decade. And I'm almost afraid to see what happened in the data that we're going to see from 2020 in the last couple of years. That wasn't available quite yet in table format, but definitely we are facing some concerns and issues for our women. And then I broke it down into what's going on in the state, and compared it to the United States as a whole. And these are rates, which of course reflect our numbers. And unfortunately, Wisconsin is at a higher rate of fatal opioid overdoses than the nation. So in the most recent estimates, the number of women with opioid-related diagnoses documented at their delivery. Okay, so these are the women who came to full term or at least term and delivered an infant, increased by 131% in the 7 years between 2010 and 2017. 2015, we had 1.3 million women of childbearing age use a stimulant in the last month. Some of those were prescribed, but if you look at the misuse of prescription, it was 1% of that 1.38 million, cocaine, meth, about 1% each, and then ecstasy 0.3. And you're like, 1%, but you think 1% of 1.3 million, that's 130,000 women. So lifetime stimulant use is 29%, second only to marijuana at 46.9%. It's more common than opioids. We start thinking about what we're putting into our bodies, whether it's prescribed or not. The use rates, I think, are pretty substantial. It's about a third of women. And we need to think about what that is doing to the woman's body and to the developing baby. And a lot of times we have to ask those questions about what is the risk, what is the benefit, where are we in that balance? In 2010, so 12 years ago, still 12.3% of women smoked during their pregnancy, and 12% reported alcohol use in the last month. So I found this graphic, and I can certainly email it to Lynn and get it to you, but I thought it spoke pretty dynamically to what is going on when we have women putting substances in their body. We think about alcohol, tobacco, and marijuana, and this is prenatal substance use. So we look at other risk factors along with those, such as maternal and paternal age, what's their education, what are their stressors, and being we do what we do. I don't need to, go through all the details of it, but we do need to think about what substances are being passed directly to the fetus, and what we can detect in cord blood and things like that. And then after delivery, what substances pass through breast milk readily. And again, it's just the impact on the breast milk supply. So think about those things. And in my next slide, we have what happens to the baby. And, it's even though we've got decades of information and data and education going out about the impacts of alcohol, we still have 12% of women that drank in the last month. Um, and fetal alcohol syndrome is very real, and there's a whole spectrum of it, and the damage that can occur from what someone may think is harmless low level use. Long-term effects for that baby, when we look at their neurodevelopment, um, ADHD, how much of that is related to their prenatal exposure, their IQ, their academic performance, their coordination, behavior problems, all of that. And I'll talk about caffeine a little bit, but when we think about something as harmless as Diet Coke or Mountain Dew, or how many cups of coffee is someone drinking in a day, um, there's that increased risk of growth restriction and prematurity, and there's a possible decrease in that executive function at school age. So it's not just those immediate impacts of having a small baby, it's through their entire life. Okay, I want to talk a little bit about alcohol and nicotine in women. 24.2% of women in Wisconsin had excessive alcohol consumption, some while they were pregnant and may not even been aware they were pregnant, putting us at 48th in the nation. That's not a very good place to be. So Wisconsin is certainly living up to their reputation as being a high consumption alcohol state, and women of childbearing age and even pregnant women are definitely still consuming far more alcohol than they should. And then we look at just the pregnant women, it's 14.2% of women in Wisconsin used alcohol during their pregnancy. So lots of things to be concerned about, and 17.7% smoked during pregnancy. Let's talk a little bit about the opioid use disorder and its effect on the women. We have an increase in the risk of infections that a person is exposed to, particularly if they're IV users. Sexually transmitted infections, and those of us in the public health world know that, sad to say, there is an increase in syphilis in our state. Right now, the data I looked at is that there's primarily in the Milwaukee area, but I hear a lot of stories about people making trips to Milwaukee to buy and sell substances. Hepatitis C, of course, with the IV drug use, HIV, endocarditis from the infections associated with IV drug use, osteomyelitis, cellulitis. I see a lot of localized abscesses and infections being reported, sepsis, injury, overdose, and death. And for the pregnancy, it's preterm labor and placental ruption. When we think about the baby, of course, there's the fetal growth restriction, preterm birth and stillbirth, preterm delivery with all of those complications, and sadly, death is one of them. We need to think about what infections are crossing the placenta and what can be transmitted during delivery itself, syphilis, HIV, hepatitis. I want to talk a little bit about the now neonatal opioid withdrawal syndrome, or the neonatal abstinence syndrome. Terminology that, if we know the primary or only substance that was used during the pregnancy now is used, NAS can be used for the other substances. I'm going to tell a little story about when I was new into my world of caring for people. I was working as a CNA in the hospital in the town I grew up in, and I was already an EMT, put me in the ER. I did great there. I didn't mind working out on the floor. The place that made me most nervous was working in OB, the nursery, labor and delivery. It just wasn't a place I was super comfortable. I'll never forget this night. They had 8 babies in this nursery. It's a very small hospital. If we had 1 or 2 babies, it was kind of a busy time. But the RN was in the delivery room with the patient. We had another person come in ready to deliver. And as I had my little bassinets all lined up, staring at me, and they're staring at each other, there was this one little boy, and he looked like a little old man. He had, of course, absolutely no hair in his little face, and kind of had a little crunched up nose, and he just stared at me all night. And I got everybody else asleep, and I go over to him and I assessed him, and he was just tremulous. And what is wrong with this little guy? I'll change his diaper and try to feed him, and he was just irritable. Took his heart rate. Something wasn't right. And I'm probably a whole whopping 18 years old, and what do I know about babies other than if you keep them happy, everybody's happy. And I went and got the nurse and I said, something's not right. His heart rate is just up higher than it should be. Come look at him. I'm really busy. This baby's coming. I'm like, okay, So she came out after the new baby delivered and looked at him. She's like, I don't know. We'll wait for the doctor to come out. And in the meantime, the mom puts the light on and asks for a cup of coffee. It's like 2 in the morning. Who's drinking coffee at 2 in the morning? So the very smart nurse that I worked with went in, so come with me, and we both went in. And she said, regular or decaf? And she's like, is there anything else? I want regular coffee. So, okay. We took the coffee back in, and she said, how much coffee do you drink a day? She said, a pot. And keep in mind, this was the 80s. And we're like the Mr. Coffee? She said, oh no, the big one. This woman drank 30 plus cups of coffee today. And what this little man was going through was caffeine withdrawal. And we kept him for a long time, watched him. Well, a long time in those days, more than his 24 hours. I think we had him 3 or 4 days just to make sure he settled. But he was very uncomfortable. And that was simply from caffeine withdrawal. And what he had was neonatal abstinence syndrome, but it wasn't anything as flashy as, cocaine or heroin. He was withdrawing from caffeine. So those new little people in our world can withdraw or have abstinence syndrome from any number of substances mom has been putting into her body. Small head circumference, lots of impact on those little bodies. So what this is a map of the neonatal abstinence syndrome rate by county of residence. And I live in Wood County, Portage County, and is where you're all at. And we're in the yellow. The grays is where there's no data. And of course, the highest rates are in the dark blue counties. Women are very ashamed. So whether or not we're getting full accurate reporting on this, it's a little difficult to say, but those are the rates as they're recorded right now. Up to 2014, I couldn't find any newer data. So let's talk about treating opioid use disorder in pregnancy. So what are our goals? What we want to do is, of course, maximize long-term recovery for the mom and minimize infant complications. And so there's some challenges along the road with that. It's very difficult for a mom to walk into the OB department or call in and say, I'm pregnant and I need to be seen. And along with that, oh, by the way, I use fill in the blank. I use heroin. I use pills that aren't mine. I smoke meth. It's very difficult to do. They want their babies to be healthy as can be, but it's very difficult to admit, confess, as sometimes they feel it, that they have a problem with a substance use disorder, because there's a lot of stigma with that. Stigma from the healthcare providers, stigma from themselves, stigma from their families, cultural stigma, just so much guilt and remorse, and yet not knowing what else to do to help them have a healthy baby, that it's very difficult for a woman to ask for that kind of help. We in the healthcare arena sometimes forget that addiction really is a chronic medical disease. It's a brain disease, and we need to treat it as that. And we need to put our own biases aside. And I have a whole talk that I do about that. There's also criminalization of this medical disorder in pregnancy. We're going to put you in jail until you deliver that baby, and then we're going to take it away. So there's a lot of fear. Sometimes it's a necessary thing. Sometimes the best thing in the world is that a woman's already on probation because the Department of Corrections has money to help women get residential treatment. But for many of the women I work with, anybody in a caring role, we all like to think of ourselves as healthcare providers, as helping professionals. We are the enemy in their world. And I spend a lot of time talking about your PO is not the enemy. Your ICW worker is not the enemy. These are the people who have the resources who can help you. So, there's stigma on both sides of this situation. And to help somebody who may themselves have been taken away from their family because of their parents' substance use disorder, it's very frightening. They know what they went through and they don't want that for their child. So, working on building those relationships and realizing that we really are the helpers. Nobody wants to wreck your family, nobody wants to destroy you emotionally, but we're going to do everything we can to keep you safe and to keep your children safe and bring the family back together. But we all got to work together. And I can't do it for you. I see Wendy's name up there. Wendy can't do it for you. And sometimes those children do need to go live other places, but it's for the safety of everybody involved. But there are some times when those hurdles are crossed and we really do become a team and we do get those families back together. And there's no better feeling in the world. And there's no better feeling in the world than helping a mom stay sober during her pregnancy and deliver a healthy baby. Um, Many times there's the social challenges that a woman faces as far as housing, transportation, access to services, childcare. Once that baby gets to be a certain age, MTM or VEO, whatever name they're using now, I believe it's VEO, but any of those transportation services, they don't let you bring your 3-year-old along, but yet you don't have a babysitter. So how are we going to make this work? One of the gifts of the pandemic and COVID was that we figured out how to provide services without having anybody leave their house. We got really good at phone calls. We got really good at figuring out WebEx and ways to provide services telehealth wise so that we can continue those services and treat women and their families. Actually, our whole staff and service was telehealth for quite a while. So we learned a lot of things. So we want to prevent opioid withdrawal symptoms. As we know, withdrawal from opioids isn't going to kill anybody, but it's going to be highly uncomfortable. And it may be enough stress that it may not kill the mom, but it may cause a lot of problems for the baby in that pregnancy. So we really want to prevent that withdrawal. And we want to prevent the complications of using stuff that's not prescribed to the mom. We of course want to improve their prenatal care. We want to get you to those appointments, get those ultrasounds done, do the glucose tolerance testing. And we want to improve that engagement with treatment services. We want to reduce those risk of complications. So we are Family Health Center Alcohol and Drug, a hub and spoke variation. And then we got a grant. So we really are hub and spoke up in our Minocqua office where I'm sitting today. So as I mentioned earlier, we are very rural and we cover a huge amount of territory. So right now, our Minocqua Center is a pilot for hub and spoke in the state. We, prior to even getting the grant, thought of ourselves as, yeah, we're this little hub. We provide the medication, we provide counseling for some of our patients, but we also spoke out to other services that provide counseling, whether it's Kohler Behavioral Health or down in the Marshfield area, maybe the county. In Ladysmith, we work with, I went right out of my head, Aurora. So we do work with the counseling agencies that the person wants to. If they've been long established, great, stay there. We consider our other primary care providers, our OB providers, let's say infection disease or GI, who's ever treating their hepatitis. We consider all of those spokes and part of their team. Even corrections. Linda at the Vilas County Jail, I think of her as one of our spokes because when I do have patients in the jail, she's right there. She's telling me what's going on. How can we work together? So we're the MAP provider, and they can get their counseling anywhere at the tribal agencies, at FRC over in Lac Flambeau County, anywhere. Um, so we are in constant communication. We have releases of information, many, many, many of them, with the partners involved in that individual's treatment plan. If they have a public health nurse doing PNCC, we want to connect with them so that we're all on the same page. We have a strong focus on counseling. We need our patients in counseling because, as I tell them, you really like coming to see me because I give you the medicine that makes your body feel great, but I need to have your body feel great so that you can really do the hard work with your counselor. And that hard work is how you think and how you feel about that relationship with that substance. And how can you work through that to make your journey in your recovery? And how can you attain that sobriety and achieve all these goals that you want for yourself? And we want to improve the person's quality of life. And you'll hear me say it again at the end, but if we can improve the quality of life of that one person, it's going to improve the quality of life of their family. And we start building healthier families, we're going to have healthier communities. And that's really a big goal of mine. And along with that, I want to break this chain. I want to stop this generation after generation of families living with substance use disorder. So outpatient treatment sources or services, what we do is we are freestanding. We're a federally qualified health center, so we're not on the main campus of MMC or MCHS, and we provide what we like to think of as TAM. MAT is what's all out in the literature that we read about, but we are treatment assisted by medication. And we also have a perinatal nurse who follows our pregnant women through their pregnancy, delivery, and for a year after that baby comes into the world. If they come to us and they have an infant, they are qualified to go into that perinatal program where they have extra case management and teaching. Jamie just started a program where we're doing baby wraps, where we'll provide the instruction, fitting, and a free wrap for that mom. And it's been really handy for the ladies that we've started with it because they also have other small children, and that frees up their hands when that baby is with them and literally wrapped to their body. Several of our staff have completed doula training, and that's just been very helpful and insightful. And the doula training that we provide has a big cultural component to it. We work with several of our nations in providing care for their members. We have care coordination. Right now, we have 2 care coordinators, and they do work with all of our program or clinic locations. They do everything from connecting to transportation, to doing reminder calls to make sure they get to their appointments, to connecting with baby clothes. We had a mom that came in, she burst into tears. She's like, when you got a baby, people are willing to give you those new clothes when you find out you're pregnant and you have a baby shower. But once they're 15 months old, you run out and you don't have that. She was able to make a phone call, and the mom was able to go to a big warehouse, pick out anything she wanted, whatever she needed that they didn't have. She got gift cards and they took her shopping and delivered it to her house. It was pretty amazing. We help women get their GEDs, HSED, whatever they want to do, job applications, all of that stuff. We like to think of ourselves as the easy button. And I'll talk to you a little bit about our model of care. We focus very much on being welcoming. Welcome to Family Health Center. Hey, glad you came back. We may have somebody who left on their own, discharged, relapsed, whatever. Either way, they're coming back in the door. Welcome back. I'm so happy you're here. We want to be trauma responsive. And there's a difference between being trauma informed. You know about the ACEs, and you know about this, you know about that. It's just their trauma. But being truly trauma responsive. Um, One day, one of our care coordinators was walking through the waiting room, and they stopped and they looked around, and they really looked at the waiting room up here in Minocqua and went back to their office, thought about it, and they're like, it's booking. All the chairs were against the back wall. It was very white. It was very bland. And who wants to sit all lined up in the chairs? The person who you're going to talk to next is behind glass when it reminds you of what it's like at booking at the jail. We added plants, we rearranged, we put up colorful posters, much different feel, much more welcoming. Um, Sometimes we get excited when somebody just shows up. We know that they used meth the day before, we get it, but they showed up. Huge step. They called. I'm not coming in because of this, this, and this. Okay, when can I see you? Um, so we celebrate many times the little things. We also celebrate the big things. We're off probation, things like that. But sometimes we need to be very positive and engaged with just the baby steps. We provide education, of course, for our families or our patients, their families, providers. I do a lot of provider education. I do grand rounds. Sometimes I go to department meetings, and then definitely community. We're very sensitive to historical trauma. We work, as I said, with several nations, and that historical trauma, and sometimes just that trust and understanding white privilege. And again, that cultural humility goes right along with that. And we recognize organic community supports. Maybe their support that they identify isn't biologically related or anything like that. It may be their sponsor, it may be a neighbor, but that person is just as important to their recovery team as any one of us. And like I said, we're the easy button. There's no referral needed. You don't need a primary care provider. You don't need anything other than a want to be in recovery. Um, we get referral calls from all over. So we'll cold call people. We'll say, yeah, we got a call from so and so, or not necessarily so, but your PO called. Thought maybe this would be a good idea. What do you think? Click. Okay, that's fine. Or your mom called and she's really worried about you. Do you want to talk about this a little bit? Hear what we have to offer? We can't force anybody. We don't do mandated treatment. If somebody's been told you need to be here and is court ordered, we don't want that. A lot of times we sometimes still work through the punch in the clock for probation. They come here with the intent, but it doesn't take long to figure out who's just punching the clock. So we help them find where they need to be best. So what we hope to do is connect people with community resources for housing, childcare, income support, collaborate with other providers, social services, the court system, drug court, CPS, and again, work through that. They're not the enemy. They are also people who can help you. We want to provide holistic, comprehensive care. I want to overcome those barriers. Again, trauma responsive, culturally sensitive. And, you know, we know the healthcare system, so we can make our own referrals. We have a patient financial navigator who can help with connecting people to different financial resources, helping them get to marketplace, helping with jobs, those types of things. We've had people bring in grocery bags full of bills, receipts, and tax papers, and Jean and her team will sit down and figure out what needs to be done to help make this good. The integrated care coordinators through behavioral medicine we work with, and sometimes we just truly need to advocate for our patients. And I've made those phone calls. I talked to Jane about this, and I just don't think that she was able to get across what she needed. And we make the phone call. Sometimes we do them together. We really work to develop a perinatal care group here in Minocqua. It's pretty, initially we spent a lot of time together working. Right now, I don't even have blink an eye when somebody's going to deliver over at MMC Minocqua. That the team there is just phenomenal. We continually work on identifying maybe it's a smaller hospital and they've never worked through a mom who's on buprenorphine products. And we work through that. How do you suss a baby for neonatal opiate withdrawal? So we talk about eat, sleep, and console. Um, so we work through the barriers, help overcome them, share our resources, send you books about the baby crying, purple crying, and we collaboratively care. Um, so again, we are aware of the stigma. We work through that and identify and overcome those barriers, provide education, collaborative care. A lot of this is repetitive because this is what we do. So what happens? Let's say CPS gets a call and they get involved with somebody who needs treatment, and you're in our service area, and they get the right insurance. We all match up. And let's say, Wendy, I'm going to pick on you just because you're in one of the boxes I can see. Wendy can call, or she can help the person call, and they'll go through an intake and they get into services. What we do first is we screen them. We'll get a call with one of our nurses. We do a nurse health screening. We do some labs. We do urine, check and see what's in there. And other than the lab, this isn't billable yet. We'll make referrals, help them get them into OB, work together with the CPS worker, make immediate referrals if there's suicidal ideation, get them into mental health, whatever we need. And keep in mind, we do have our very own psychiatrist. So unless it's got to be the site of crisis, can't be in crisis because then we'll connect you to the crisis workers, but we do address those mental health needs with our services. Again, self-referral from a professional. We have the PFN, helps with all of those things. We do have some grants that will, with the HOPE grant, help pay for medication. And the care coordinators talked about that, and the perinatal nurse. We have that nursing assessment, screening labs, education about the program, what our expectations are. Everybody gets Narcan, whether you're coming in to see us for alcohol, everybody gets Narcan and how to use it. That, again, we've done all that and we've not sent a bill yet. So then there's an assessment by one of the counselors, health evaluation by a nurse practitioner. Those things are billable. Pregnant women, if they come to us and in their history, if they call me at 5:05, and I'm going to jinx myself, I'm sure, but if there's a call at 5:05 on a Friday, guess who's working late? A lot of us. Okay. The woman does not need to be in full blown withdrawal, opiate withdrawal. We'll get them on medication as fast as possible. We do use the combination product. This has been researched by the American College of Obstetrics and Gynecologists, and with our team at MCHS, everybody felt that with it being safer to have that form of buprenorphine out in the community, that was what we were going to go with. It's very protocol driven. We have 3 days of direct contact with the patient, and then we go and lengthen it out from there twice a week for a long time, a couple months. They enter our treatment assisted by medication protocol. And I just want to do a little bit about planned pregnancies are different than actively using. When we have somebody who's in our program and they plan a pregnancy, it's really exciting, really exciting. We work with them, we get them on the right vitamins, we do all sorts of teaching, get them patches, get them off cigarettes, whatever needs to be done. And it's a very coordinated effort with their OB provider. When we don't take them back and say, no, back to level 1, you're pregnant now. What we do in level 1 of treatment assisted by medication is that they have twice a week contact, once with a counselor, once with either our medical staff or their OB provider, perinatal nurse. We are in constant contact to make sure that that mom has everything she needs and has her medication. We get them into group, but they need to have 2 appropriate urines before moving on to the next level. We use a stability index tool for that. So in the initial phases of their treatment, it is very closely monitored. Once we get into it a little bit, as long as their pregnancy is going well, we're going to follow what the OB providers recommend. They only see me once a month. Jamie will have more contact with them as the perinatal nurse. Counseling remains, and we just keep moving through. If this is early in their pregnancy, they may stabilize nicely. They may graduate from group and just spend time with their provider once a month, their counseling provider. Somebody will see them once a month medically, random urines. And as they go through the program, the amount of medicine they're getting at a time lengthens out. Solid recovery. I'm just going to skip through this a little bit. We do work with doulas. Again, some of our staff has been trained as doulas, but we do provide referrals to doulas. We pay. We've written some grants and we've been able to fully fund that initial training. Again, it is culturally sensitive, and they spend, I believe, about 4 hours learning about the indigenous populations' cultural needs and being sensitive to that. And then 6 face-to-face visits are provided through that program, and they can provide a presence during delivery. Again, COVID kind of put a little wrench into that, but it is possible. Contact by phone and text, and ideally it's a peer who's in recovery. Outcomes. We want to decrease that rate of NAS. Recovery for the family, like I talked about before. We make a healthy individual, healthy family, healthy community, and it's wonderful. This is some of the data that we have collected. What I like is that when we look at the numbers, we're seeing definitely a decrease in the number of children not residing with the parents. Okay, that's good. Our numbers here have dwindled a bit, not quite certain why, but you can see we had very good birth outcomes with 0% in the last couple, years, pretty consistently, pretty low. Unfortunately, we did have a fetal demise. Mom had used meth, a lot of meth, and meth being a stimulant, it vasoconstricts the placenta and the blood flow, and the placenta just let loose, and the baby was stillborn 20 some weeks along. So that was our loss here in 21. But as we're looking at opiate-free urines, 100%. So that's very good, very good. Okay, so sorry, I clicked on the wrong button here. So those are my references. I'll be happy to share those with you. So what we are with Family Health Center is we're addiction medicine with a primary care eye focused on the new family. So we really want that holistic approach to the care. We're just not going to dump buprenorphine into women's bodies, and we're, just not looking at their substance use disorder. We're looking at the whole picture. So there's our road to recovery. I know I've talked a lot. I know there's a ton of information. I guess if I was to go back to anything, I'm more than open to taking questions. Our big goal, okay, we got to be coming here close, was the picture of, again, I'm not very tech savvy, so I do apologize, and hopefully we're not going to trigger any seizures with all the flashing here. There, that's what we want. We want a healthy baby by preventing the exposure to the substances. And yes, caffeine is included, alcohol, stimulants, opiates, weed, tobacco, all of it. Any questions? Discussion?
Thank you so much, Paula. I know there's one that I have, and it might be one that others have as well. Wondering if there are certain intervals within pregnancy that are more crucial as far as the exposure to certain substances.
That's
More detrimental.
It's really hard to say, because in each trimester, that baby's working on growing different parts. In the last weeks of pregnancy, they're pretty much feeding and growing. Early on, sometimes even before a woman realizes she's pregnant, sometimes if they're really using a lot, they may not know until the baby bump is showing that they're pregnant. It's really hard to say if there's one point that's more critical than another. I think all of it. Probably the more dangerous substances are the stimulants, just because of the vasoconstriction and the impact. Once you shut that placenta off, it's very hard. There's no reversing it. I think fetal alcohol, it's still out there. It's still very dangerous, I think. It's like what's flashy at the moment. Right now, there's a lot of money out there for opiates, but there's a lot more stimulant use. Um, sometimes you got to follow the money. But then when you look at the outcome of these babies that are born and what their challenges are, it's hard to just say, pick one thing. What are we going to work on? Just this one thing. I think we need to take that really holistic approach to our individuals, to our communities. Um, the hard thing is that we don't have a medicine we can give somebody to treat stimulant use disorder. So then we have to look at what makes people want to use the stimulants. Why is it so available in our communities? What is the urge? Why do people use, and work on those kind of root causes. When we have patients that come through our program and all of a sudden something pops up in their urine, I have it taped right here on my laptop. What happened? What happened to you? What was going on when this triggered? And then we talk, sometimes I have to say, okay, that you really need to talk to your counselor about. You need to go talk to Kevin about that. Because your reaction to that situation, what do you think? Was that a good choice or not? And go through there. So, I think the sooner we can get a pregnant mom into treatment, the better. I think achieving sobriety and getting them into recovery before they even have a baby would be best. And we've got a couple young women right now that have achieved their recovery, and they've gotten married in the long term. And one got married and one's just in a very stable long-term relationship. And they are super excited to be planning a baby. And it's fun to be excited with them and see where it goes. But I guess I probably didn't answer your question. I didn't have sorry, second trimester, but it's hard because when those little cells are making a little being, there's very important stuff going on at a lot of different times.
Oh, that makes sense. Are there any other questions from the group?
And I think thinking about mom, getting mom as healthy as possible, in addition to treating her substance use, mentally, emotionally, financially, all of that is so important so that it helps that baby be successful. Sleep in heavenly peace. They've been a wonderful group to work with. They provide beds for children who don't have beds. We've worked with them, and the mom came back in. She had a 2-year-old, and she's like, I can't believe it. It's the first time we have had a bed. And she and the 2-year-old are sleeping in a twin bed. She's like, they brought everything. They brought me sheets. They brought a comforter. They brought pillows. If you've not accessed them, that's a wonderful resource for, I believe it's 2, because they want them to be able to be safe in a bed. So toddlers up. We're very excitedly working with Wood County and with now Clark County. They just submitted a grant to bring Vivitrol into the jails. I guess we could talk about Vivitrol. I learned as one of my women who was on Vivitrol got pregnant, and then we panicked about, oh my gosh, what are we going to do? Vivitrol actually increases a woman's fertility. So if you're working with a woman who is currently not pregnant and on Vivitrol and maybe doesn't want to have a baby, birth control, extremely reliable birth control because it does increase the fertility. It happened that she stayed on her Vivitrol shot through her pregnancy and had a wonderful, happy, beautiful baby without any complications. So it's not advised to start a woman on naltrexone and the Vivitrol shot if they haven't already been on it, but there's not any reason to stop it. Lots of research from Australia demonstrating that.
Yes, thank you so much, Paula, for your presentation today. And thank you everybody for joining us. And if you haven't already, please make sure your name and organizations in the chat if you want a copy of this presentation, also your email.